end, not yours. Femoral stem on there. Anyway, why don't we start? So I'll be talking loudly so I can hear you, I'm afraid. So for those of you who haven't met, I'm Pico Questions. I am one of the spine surgeons here at Parks, and I'm the honorary clinical, senior lecturer in orthopedic surgery here with Physio. So what we're going to do today, this is week 3 of the academic skills training program, some of you were here last week, and the idea is to cover some of the important foundations of being a clinical researcher. Okay, so if we go to slide 2, the learning objectives we've all seen before. And he's not moving on. Move on the slides. There we go. And you can see what we're aiming to cover over the coming couple of weeks. And today we're still quite near the top with selecting and justifying a suitable, with formulating a research question that can be answered. Okay, so move on to the third. So with week 3, which is this week, the idea was last week we were going to leave you with an exercise to design a research question following what we talked about, which was that Pico and that finer kind of scheme to design and refine a research question. But everybody looked pretty, like you'd had quite a long session with the professor beforehand, so we decided not to do that. But what we're going to do this week is to ask the question to be or not to be, and that's to be or not to be in Klingon. You can tell it was late night when I was writing these. What we're going to do is do an exercise for 10 or 15 minutes, probably in pairs or on your own if you like, to create a research question using using those frameworks of the Pico and the fine end, which will come up on the slide in a sec. And then we're going to talk through those research questions and go around the room and essentially mug Professor G's brain for his thoughts on your research question and how you might refine it to make it answer. So essentially an exercise in setting a research question. And then what we're going to do is I've written a slide for the 5 points that I think are the most common errors made in research questions, and we'll ask Xavier what he thinks his are. Go on to the next one. So here's the exercise that I propose, and we're going to consider the treatment of femoral fracture. I had to choose an orthopedic thing, and I chose not spine. Okay, so for those of you who don't know, we can treat femoral fractures in patients of any sort conservatively, i.e. let them heal themselves by doing whatever, with traction, so like you've seen in the old movies, stretching the leg out to keep it straight, or with lots of different surgical options. And these can be with frames on the outside of the leg, or they can be bits of metal applied to the bone inside the leg. And those bits of metal can be inside the bone or outside the bone, but under the skin, if you like. So what we're going to ask is that we spend 10 or 15 minutes designing a Pico question, so that's population, intervention, comparator, and outcome, to answer a question about the best way to treat a femoral fracture in a population you choose, with an intervention you choose, and a comparator you choose, and an outcome that you choose, all right? Just remember that these research questions are what we essentially submit to like the NIHR or the MRC, the funding bodies, okay? So you want it to fit those finer criteria to make it so good that the NIHR give you £1 or £2 million to do your research project. That's the sort of budget you're talking about when you apply. So this is the finer criteria that you'll remember from last time. So your question has to be feasible, so it has to be doable, right? It's no good saying, you know, oh, we'll send half of them to the space station or something to see what happens in zero gravity. Right? It has to be interesting. Right? And that, I think, is really important. It's got to be interesting for you to plug it away for a couple of years. It's got to be interesting to the funders because they want to fund it, and to the patients. Okay? It's got to be novel. It's got to add something to the information we already have. It's got to be ethical, of course. It's no good doing something unethical because A, that's not right, and B, you'll never get it funded. And it's got to be relevant. Like I say, it's no good sending it to the space station because we're never going to send patients from East London to the space station. So I'm going to suggest that we spend the next 10 or 15 minutes, probably in pairs, now there's more pairs shown up, and those of you online can do it either in breakouts or on your own, just coming up with a Pico question that you can share with the group afterwards, and we can ask the professor to pass judgment on each of those and maybe help refine it. Okay, just an exercise. And then this is the last week we talk about the research question. All right. So you get yourself into pairs or into breakouts online, and let's do that. And then we'll come back and say 70. So why don't we say 5 to 1? So what's that? 12 minutes, 13 minutes, something like that. 5 to 1, 1 o'clock, something like that. Big hit. There you go. You can get closer to your friends. Let me go and get you some napkins so you can clean yourself up. Painful.
I didn't realise I left the top of this open. Put it in my bag. Thanks, mate.
Well, I guess it's telling them 40 seconds. So.
Oh no. Somehow
Okay, so I think everybody's back online from the online breakout room now. So what we'll do is we'll go around. Why don't we start with the people in the room? They've worked ferociously hard for the last 20 minutes. So we'll start with the groups here, and perhaps, Professor, you could offer advice and pass comment and so on. Yes, but of course I can. It'd be a pleasure. Can you hear us still?
I can hear you, yes.
Excellent. Okay. So we'll start with the excellent team on the far side there. So we've been working in pairs.
Who was in this team? Who was in this team? Taking
Jamie.
notes.
Jamie and Becca. They
Okay.
worked the hardest actually, so it should be really good.
Okay, fine.
Okay, so tell us your question in the Pico format.
So our question is, does a quadricep strengthening rehab program with virtual physiotherapy improve quality of life and return to work compared to standard NHS physio in adults aged 18 to 55 with femoral shaft fractures?
Did you get that?
Okay, that was a research question, but it wasn't quite in the Pico format, was it? I think you had most of the Pico things, but just reformat it for me because I'm not sure what your outcome was.
So our outcomes.
So just run it through the Pico structure.
What's the Pico? What's
We get a prompt for Pico.
Oh.
You've gone in sort of, you're going in like
No.
So population,
or something.
intervention, comparator, and outcome. So
So,
make it really obvious to him because he's the funder.
so our population is adults aged 18 to 55 with femoral shaft fractures.
Yep, got it. Interventions.
Intervention.
So our intervention is a quadricep strengthening rehab program, which is very specific. You can expand if you want. With
No, that's
virtual-
fine. That's fine. Versus standard of care. I remember
versus
that.
Standard care.
Yeah.
And what was the outcome?
So outcome is quality of life and some kind of return to work measure.
Okay. Okay.
So what do you think?
So I like the question, but I would say to you, how is quality of life relevant to me as a patient with a femoral fracture? Why did you choose quality of life?
Because everyone does.
Yeah.
No, the NIHR don't like that. They don't like you to say because everyone does.
Because we've obviously done lots of systematic reviews into what outcomes for adults with femoral shaft fractures.
Okay.
So what
there's lots of them
alternatives
already.
might there have been? So you had return to work as an additional outcome, but what other types of outcomes? I don't mean the actual instruments, but what other things might be important to patients?
Mobility, function.
Yep.
Outcome.
Function. Yep.
We're not so interested in like biometric data. We'd rather have self-reported
Okay.
data. Return to work, lower limb function. What do you think of?
Yeah, I feel like return to sport.
Yeah, return support. Yeah. What about pain? I just broken my femur.
Oh yeah, pain, that'll be a good one.
Baz, we could have a nice Baz in there.
Okay, so I think your Pico was well put together. I would just, on the finer criteria, I'd say, does the question answer the precisely most relevant question for the patient population that you're studying? So most funders, NIHR are hugely explicit about it, but most funders really want you to ask the question that patients want to know the answer to and demonstrate that in your application. And one of the key things, patients rarely tell you which interventions that they want to know about. That's where your expertise comes in. And the population kind of sort of sorts itself out in the sense that you're looking at adults with femoral fracture. So the bit that the patients really, really, really drive is how should you measure outcome? What matters to me? So you need to think about that when you are putting your application together. And that's one of the big areas the PPI team can really, really help with. Okay, next one, Brett.
All right, so the next pair worked almost as hard, but not quite as hard. So we'll see what they come up with. So you're gonna have to yell so that they can hear online. I'm trying to improve the sound for you.
So our question is, does early resistance training enhance functional outcomes for adults below the age of 60 with high energy femoral shaft fractures?
Did you get that?
Yeah. Again, you've written a sentence, but I think I picked it up. I was tuned into sentences. These are very physio-heavy interventions. I don't know what you're.
So you literally have a room full of physios. That's where your brain goes.
What's happened to the surgery?
You have to go to
Okay.
Fix this.
So is that novel? All I ever hear about from physios is resisted strength exercise programs.
The way that we're going to do it is novel.
Okay, so tell me about that. How are you going to demonstrate to the funder this is something different?
So it's going to be a more intense program than they would normally have.
Okay.
How do we turn the volume down on that? We can turn it up on this. If that helps.
I'll turn it off on the thing.
Okay, so let's flip it on its head a bit, Jess. How would you go about writing the 2 paragraphs in the application and sourcing the information you needed to convince me that this was novel? The Klingons are clearly landing in your machines there. I don't quite know what's going on.
Oh my God.
You can only have one mic on. I think that's the key thing.
All right, now you should be able to hear us better.
That's beautiful. I love it. Okay, so Jess, how are you gonna go about filling in the 2 paragraphs in the application that convinced me it's novel?
Struggle. Yeah, I don't know.
So I think there's a balance here. The first thing you got to show is that that it's novel. It's not been done before, or at least you're repeating the experiment because there's some problem with the previous experiment. So that comes down to a systematic review of the literature, and I think we've got a session about systematic reviews later on. So systematic reviews are really helpful at not only bringing together all the information for practice, but bringing the state of the evidence up to date so that you can apply for the next appropriate question. And the really key trick is to land your application at the sweet spot in time where there's sufficient evidence to suggest that your intervention is effective or may be effective, but insufficient evidence for it to be rolled out in practice and funded. And that sweet spot is really difficult to hit. And normally you apply, in order to land, you have to be applying before it's really kind of considered okay. And the money is often given in the belief that this is an emerging kind of package of care. And then during the course of the study, people get much more on board, and then you're trying, you go from a position of not being able to recruit participants because surgeons and physios don't want to do it, to a position where everyone doesn't want to do the study anymore because they've already decided they know the answer. So hitting that sweet spot is really tricky, but it's really important to get funded, because if you're either side of the sweet spot, you're not in the right place for the funder, and each funder has a different sweet spot depending upon the available evidence. So the types of studies we run in London at the moment, they're all far end pathway type studies, but there are other funders, MRC, Wellcome, EME, who are interested in funding much earlier phase work, which hopefully we should get involved in over the next couple of years. Okay, good. Excellent. Well done.
All
Who's
right.
next?
Boys at the back of the bus there.
The hardest workers.
Unfortunately, another physio. Yeah.
Oh, Manny, killing me.
I was going to go with something self-salvage related, but it's been taken.
Beautiful.
Does including post-op muscle stimulation improve functional outcomes compared to standard care in patients 18 to 16-year-old with femoral shaft fractures?
It's a little bit more novel.
Okay. Yeah, so just describe the intervention a bit for me. I'm a bit ignorant about what you're talking about.
So the use of electrical muscle stimulation in addition to the rehab that they would usually get in the outpatient setting. So compared from standard NHS care versus the addition of muscle stimulation through exercise and rehab.
Okay, so I like that. I think it's got many of the elements of finer in it. The thing that's jumping out to me in my mind as a reader would be, how feasible is this? So just convince me that you could actually do this in clinical practice. When does the intervention happen? How do you access the patients? How do you get them to adhere to it?
Access anyone that comes through outpatient physiotherapy. The evidence for muscle stimulation at the moment tends to be through sport-related ACL and some arthroplasty rehab, which is not necessarily widened, so it has the scope to be widened through that. We can capture any randomized patients through the gym-based rehab and provide. The only feasible aspect to it would be that it costs about £2,000 a machine.
Right. Okay. And does the patient have to take the machine home?
Yes.
Okay. So £2,000 per patient.
Per
It
patient.
still costs that much?
Yeah.
No.
How long does the patient have to take the machine?
We can measure it over a 12-week course, maybe 6 months.
6 months.
Potentially.
So every machine can service 2 patients per year.
I think I've seen machines for about £1,000, if that helps.
I'm sure they're cheap.
Yeah. Or there should be some.
That's more expensive than my surgery.
You can buy TENS machines for about 60 quid.
Exactly. Muscle stimulation.
Yeah,
I
but
think you're overselling yourself.
I thought it was £100, but yeah.
Okay, so we will talk about this in more detail, but there's
Cathode found
types of costs. There's different types of costs. So when we apply to funder, they're normally interested in funding research costs. So research costs are like you lot, cost a fortune, and you're funded through the CRN, and we get money through various different mechanisms, partly from the grant, partly from the CRN. But research costs are to pay for us to do the work, pay for the statisticians, pay for the buildings we're in, all that kind of stuff. And then there's clinical costs, and clinical costs are in some countries part of the research. So in Australia, if you participate in a research study, the research study pays for all of your clinical costs as well. So if you're going to do a study of knee replacements, that would be funded by the study as opposed to by the hospital. But in the UK, we don't do that. So clinical costs are expected to come out of the NHS. And we recognise that if you have a femoral shaft fracture, there is a series of costs that are going to happen whether or not the research takes place, right? So you're going to have your inpatient stay, you're going to have your treatment, then you're going to have your rehab, and we cost that up. And then what we're really interested in, what we have to tell the funder, is what the excess treatment costs are. So the excess clinical care costs associated with the research that we're proposing. If we want to do a study of 500 or 600 people, that just gets multiplied through, and that could come to quite a lot. Now, to give you an idea of what the benchmark is per site for the duration of the study, they will sign off about £5,000 worth of excess treatment costs. Most sites in a randomized study might be recruiting anywhere between 1 and 10 patients per month. So something in the order of 10 to 100 people per year. So if half of them are going to have this machine, and the machine costs £1,000, and you recruit 50, then, you know, quite quickly you're getting towards your excess treatment costs. So all that does go through the hospital before they sign up to the study, and we have to tell the funder that. So feasibility is often about, people think about it as in how fast can I recruit the patients, but you should also think about how can I afford to fund the study, both the research costs and the clinical costs or the excess treatment costs. Both are really important, especially for novel treatments that are not currently in practice. But otherwise, that's a really good, doesn't mean it's impossible. You just have to make sure it's under the magic £5,000 hurdle, under the bar.
Okay, so not a bad one.
Not bad.
That's good.
No, it's a good one. Good one.
We'll move on to the last pair here. I'll just turn the camera slightly for you, who no doubt have a very surgical trial to run.
This is a very good one. So the question is, does hydrotherapy improve return to function after femoral shaft fracture in 4 to 10 year olds compared with land patient as a pediatric population between ages 4 and 10 with femoral shaft fracture? Intervention is physio plus hydrotherapy, control is normal physiotherapy, and outcome is functional outcomes at 1 year or return to normal activities, which can be measured in different ways.
Okay, good. I like it. I like it. So, so I'm already thinking that I've got to build a swimming pool in order to get this study over the line.
Got one.
We've got one. We've got one. What about other study centres?
Wibbs Cross has one. It's not going to be
There's one in Hearts and Essex Hospital. They're everywhere. Hydro pools are everywhere.
Who says it's going to be a multi-site randomized control?
The NIHR will.
Okay, so so you'd have to convince me that hydrotherapy was already built into clinical practice, but it sounds like there's more pools than I had anticipated. The thing that I'm particularly interested in, though, is you said you're going to measure functional outcome at 1 year. Why did you choose 1 year?
Well,
I don't know.
why
really.
did we choose 1 year?
I think we were thinking of return to school, physical activity, and just
4-year-olds don't go to school.
yes, they do.
Well, some do, but not all of them. What about 4-year-olds that don't attend reception?
Then would probably start from 5. Thanks for that.
So you have to make sure your outcome is relevant to all your people. So one of the things in hip fracture, because 1/3 of our people have cognitive impairment, you have to have an instrument that they can complete. Many instruments are designed with only subsets of the population involved. So one of the disadvantages of the timed up and go test is you've got to be able to get up and go. Otherwise you can't score it. There's no way of coding that they couldn't get up. So if you're not an ambulant patient, you can't do a timed up and go. There are other physical performance measures which you can score people for that are non-ambulant. So thinking about your instrument and its applicability to your population is really important. but part of the instrument is when you measure it. So how many 5-year-olds are not back at school or not returned to full function after a femoral fracture at 1 year?
I guess it depends what you define as function, if it's return to their sporting activities or just returning to PE.
So how many 5-year-olds or 5 to 10-year-olds do you think are still attending any type of clinical contact, whether it be rehab services or surgical services at 1 year after a femoral fracture?
No idea. I mean, we would have to back all this with quite a hefty systematic review. Not great.
Yeah, but you know, sure, all of this could be backed up by lots of review, always, but I just don't buy that 1 year is the right time to measure it, because everyone's going to be better at 1 year. The chances of your intervention showing a difference at 1 year, considering that everyone's going to be back to pain-free normal function, is pretty slim, I would suggest. So there's a window of opportunity where your intervention hasn't yet had a chance to outperform the other intervention. So that's too early, because everyone's just getting better because they have had their fracture fixed. They haven't started rehab yet. They're on painkillers and they're starting to feel a bit better. They're just kind of getting ready to go home. They're thinking life's not too bad. You haven't really given your intervention a chance to impact on outcome at that stage. And then there's the other side of the slope where the two groups have come to merge together because they've all hit their ultimate achievement. Your intervention might cause a long-term step change, but many interventions don't. Most interventions that we do, certainly in trauma, have a potential to accelerate you getting to your ultimate recovery, but they don't really change your actual quantum of recovery. So if you measure too late, you don't see a difference either. So what you want to do is you want to hit that sweet spot in the middle where they're maximally different. And that requires you to do some preparatory work to figure out normally. So you want to be able to track natural history. So some of the feasibility work is about measuring outcome at multiple time points so that we can hone in on the time point where we think there's going to be a discrimination between the arms. The other approach is to ask patients when they think it's most important. So time of outcome measurement is really, really important. If you get it wrong, your study will never show a difference. But that was good. That was a good one. I'm amazed how many pools we've got. I've learned something new.
Brilliant.
I thought hydrotherapy is just for vets.
Should we hear from the guys online?
Yeah, let's. We had a good breakout room. Lauren sorted us out.
Abdul and Yassine, do you want to?
Hi.
Hello.
We didn't
like,
completely finish. Yeah.
Yeah, compared to the rest of them, we spent a lot of time talking about ethics instead of the question.
That's okay. Tell us what you've got.
Okay, sure. So we got kids under 3 who are admitted, who have like a background of some sort of osteogenesis, like imperfecta, and then resulted in a fracture. The intervention, to be honest, we haven't got an intervention that we change, but we were just looking at what would compare it against, and Professor Griffin was just helping us with that. So obviously there's gallows attraction, or the speaker. Yeah, that's as far as we got. We were talking a lot, to be honest, with Professor Griffin, who was teaching us.
No, you guys did well. So we talked a little bit about trying to make things more interesting, didn't we? Somebody had, I can't remember which of us had the idea about the osteogenesis or other dysplasias. The flip side of that is, which we didn't talk about, is feasibility. So the more quirky your population, which might tickle the fancy of your funder or might answer a really burning question that we've never had an answer to before, which is true for osteogenesis. It's true for other rare bone diseases. The flip side of focusing your study on answering a question for that quirky group of patients is they're normally small groups of patients, and so you don't have many patients to work with, and then the feasibility of recruiting your study is really difficult. So typically we do retrospective large data series type of work around rare bone diseases or rare musculoskeletal diseases in general. And in fact, there's a group in Oxford that are called RUDI, which is the Rare Bone Disease Registry. And they just collect families prospectively, collect information about them, because the diseases are all so rare. They just have to track the genotypes in order to be able to study what happens to them. But it's nearly all observational work. So quirky, it's very quirky. They produce some really fun stuff in 3 people with certain genotype, but it doesn't have wide application, and getting it funded is a nightmare because you're only going to help out 3 people. There is actually a special NIHR rare diseases funding pot for specifically that reason.
And that comes back to is it generalizable? All your populations, children and so on, they're all very, you can apply that to a population wherever in the world people are having femoral fractures, right? If you have a small group of, say, OI patients with so many different interventions that all require, A-level university teaching hospitals for bone health and preventative, treatment and so on, that population might not then be generalizable to the rest of the world, say, and so on. So, the smaller, the more niche the population is, and the other parts that play into their management can influence how good your research is when it comes to the real world. So look, these are the 5 sort of common problems I thought of, or I've come across in my limited research career to date. And I'm sure the professor will have others, but I always find defining a population needs quite a lot of thought for exactly that reason, to maintain its generalizability, so that when you publish that paper in the New England Journal, it applies to as many people around the world as possible. Finding an interesting focus, I think we've probably seen that in these discussions. It straight up has to be interesting. It's human nature, isn't it? No one wants to fund the boring stuff when there's something just a bit cooler to do. It's just a fact of life. A lot of people don't necessarily know what's gone before, so there are millions of papers. I added it up for the BOA meeting for research, something like 2 million, citations in musculoskeletal health from, when records started, if you like. Somewhere in there, somebody has touched upon your question, the chances are. And finding that is sometimes challenging, and a good systematic review is easy to say and really hard to do, but is a necessary step, because you don't want to duplicate, and you want to kind of either improve their methodology or apply it to a different population, or kind of disprove their theory to make it relevant, don't you? We talked a bit last week when setting a question about describing a topic rather than setting a question. So a question has an answer, and you just don't know what that answer is, but it's either yes or no, or it's left or right, or it's true or false. And so you must build your question and work on it until you get to the point where you go, this is what the question I am testing. And if you have an open-ended question, you'll end up with an open-ended answer. You can't then necessarily apply to clinical populations. So keep working on those questions until you get a question that has a right answer, and then work out how you're going to answer it. And then, this has come up in nearly every discussion, hasn't it? Asking an unfeasible question. OI is great, but there really aren't many kids with it. It will take you donkeys to get together enough of a population to start doing some, robust statistical analysis on it, and so on. Or asking a question where you want people to, older patients to plug themselves into an electric stimulator, you might find actually, they don't want to do that, and so on. So your question has to be feasible, and we'll come across this more and more over the course. But that feasibility comes from all sorts of directions: financial feasibility, actually scientific feasibility, ethical feasibility, and so on. But those are the ones that I've come across, Professor. What about you? Have you got sort of common mistakes that you've had in the last couple of minutes that?
No, I think we've covered them in the discussion. I think what I would add is just that, Brett right now is leading an application to NIHR, and we have a call a week at the moment as we go through to stage 2, and I don't know how many calls we had at stage 1. We've already written a stage 1 document. And we are still, there must be 10 of us on those calls. We're still arguing about the Pico, essentially. We're not doing any other work. And and I don't mean to trivialize what we're doing. What we're doing is really important, but we are hammering through the Pico and the finer components of that work to make sure that the Pico ticks each of those boxes. So it's easy to look at these slides and think this is a bit Mickey Mouse. This is, of course we've got to write a Pico question. Fine, I'll just do it. But the truth of it is actually 90% of writing grant applications about getting this part right. The rest is whatever methodology you're using has been done before. You're very unlikely to be writing a totally brand new methodology. And so therefore you don't need to really do anything in there. You just pull the recipe book down for whatever methods you're using. But what hasn't been done before is proposing the question properly. So we should really focus on this. This is basically, whenever I write a grant, this is what we spend our time doing. And I write, one every 2 months. So this is a big part of my job, just going through Picos. And yeah, you get better at it with experience, but the essential process that we're going through is exactly what we've just done in quick time in the room today.
Brilliant. Any questions, anybody? No, there never is. Okay, well, we'll draw a line under it there. We've gone 1 minute over. Next week, we're going to spend a bit of time talking about trial design and different kinds of trials. Some of which, hopefully all of which you've encountered at some point, but we'll talk about those a bit more. And there will be lunch, so do come. Okay, thanks for joining us online. Yasin and Abdul, nice to see you, and I'll be in touch with you guys. And yeah, see you all next week.
Great, I'll be in the building next week. See you all then.
Thanks very much.
Thanks a lot for your time.
Thank you. Bye.